Hello, and welcome to Quality Bites, brought to you by the Quality Improvement Team at Bradford Teaching Hospital Foundation Trust. This is one of our series of bite-sized training videos for BTHFT staff. Each video introduces a quality improvement topic or tool which can be used to support quality improvement projects across the Trust. This Quality Bite is going to focus on the Model for Improvement, which is promoted by the Institute for Health Improvement, the IHI, and is the improvement model we use here at Bradford. This session will specifically cover the second question: how will we know that a change is an improvement? At the end of this Quality Bite, you should understand why we measure continuously and how this differs from measurement used in clinical audit and research. Be able to describe the different measures used in quality improvement projects and understand how to display data for improvement. So, how do we know that a change is an improvement? The simple answer to this is we measure. Measurement in quality improvement is not like measurement for research. We don't need loads of data to know if something has improved. Measurement in quality improvement is also not like measurement for clinical audit, which gives us a snapshot from fixed points in time, but it doesn't tell us what's happening in between. In quality improvement, we use continuous measurement to help us with where we are going and that bit in the middle, which is a vital bit of the jigsaw that we need to understand. Both clinical audit and quality improvement need baseline data to understand where we are, and both will let us know when we have arrived, but we never completely know how we've arrived with clinical audit because we don't test the changes in a systematic way. We've explained why we measure continuously in quality improvement, so the next step is for us to understand what to measure. We use 3 types of measures in quality improvement. Outcome measures are the ultimate validators of the effectiveness and quality of healthcare, but can sometimes be difficult to define and may have time lags. Outcome measures should link directly back to the aim and reflect the impact on patient care. There should only be 1 or 2 outcome measures for each quality improvement project. Process measures are important in quality improvement as they describe whether or not clinical care has been properly applied, or if we are doing the things we say we should do. From an improvement point of view, they make the important connection between behavioural changes and outcomes. If you just measure outcomes, you cannot be sure the changes actually occurred in practice and therefore cannot link improvements to outcomes. However, if you just measure process, you cannot be sure if the outcomes have changed and the aims achieved, and therefore there is a risk that the process improved but the outcomes did not. Process measures are usually easier to define, and we recommend you develop between 4 and 6 for each quality improvement project. Finally, balancing measures reflects unintended positive or negative consequences of change. For example, if you have a project that aims to reduce the length of in-hospital stays, you might want to consider monitoring emergency readmission rates. Balancing measures are the most difficult measures to define and are not always immediately obvious. You don't necessarily need a balancing measure from the start, but do keep a watch out for potential unintended consequences that might be happening as a result of your improvement project. If you spot something, it is worth starting to collect the data to see if there has been a change since you started your improvement work. So let's have a go at developing our improvement measures for our fictional hand hygiene problem on Ward 16. Those of you who have listened to the earlier Quality Bite on what we're trying to accomplish and setting an aim will know we've used a hand hygiene problem on a fictional Ward 16 as a theme for our improvement project. We developed a SMART aim for our project, which is to increase compliance with hand hygiene standards on Ward 16 by 20% by the 30th of September 2021. You are the ward sister and you decide you need to do daily observations on all staff regularly working on or visiting the ward. You also ask staff to self-report hand hygiene compliance. And finally, you put a smiley face drop box for patients and visitors to confirm they are happy with the hand hygiene standards they have observed. Now we need to think about developing some measures. Let's start with the process measures because these are easier, and also in this case, the aim relates to process and not patient outcomes. These are just examples to try and explain the difference between the measures. And if you were doing this in real life, you may come up with completely different measures. The examples we have are as follows. Percentage of staff when observed using the correct hand hygiene technique when washing hands. Percentage of staff when observed with cleaning their hands at each key moment. Percentage of staff when observed bare below the elbow. Percentage of staff when observed who dispose of paper towels without touching the bin lid. Percentage of staff self-reporting compliance with hand hygiene standards. Number of patients / visitors reporting yes to being happy with hand hygiene they have observed. Number of new infection rates that may be attributed to poor hand hygiene practice. Volume of hand gel used. And number of time hand gels run out before routine refill. The first 4 measures relate back to the daily observations done by the ward sister. The 5th measure relates to staff self-reporting. It would be interesting to see if there are differences between this and the observations. Measures 6 and 7 are outcome measures. You could get a consensus from staff about measure number 7 at a daily safety huddle. You are not saying that new infections are definitely caused by poor hand hygiene. You are making an assessment as a group as to whether the infection could be caused by poor hand hygiene practice. Finally, you might want to develop a couple of balancing measures about the volume of hand gel or soap use, because an unintended consequence might be that these are running out quicker and you might need to factor in more frequent top-ups. Once you have decided on your measures and started to collect data, it's time to think about how to display the data. In quality improvement, we use run charts to plot the data over time. We also use small amounts of data collected frequently. Daily or weekly data allows you to see changes quickly. If you are relying on monthly data, it will take you a long time to have enough data to start seeing changes. Here is an example of 2 different ways of displaying the same data, a table versus a line chart or a run chart. You can easily see from the run chart that something happened around the 12th of April. And that is not as easy to see on the table. Run charts visually allow us to see very quickly when changes have taken place, and they are easy and simple to produce in Excel. There are certain rules to them which you need to remember, and we have a video saved on our YouTube page developed by the Institute for Health Improvement, which explains run charts in a lot more detail. This brings us to the end of our Quality Bites on the Model for Improvement question 2. How will we know if a change is an improvement? You should now understand why we measure continuously and how this differs from measurement used in clinical audit and research. Be able to describe the different measures used in quality improvement projects and understand how to display data for improvement. We hope you have enjoyed this session. For more information, or if there is anything you'd like to explore further, please drop us an email at qualityimprovement.team@bthft.nhs.uk. Bye for now.